Thank you, everyone. It's 3:30. The Knox County Commission is scheduled to meet at this time and place, along with representatives from the Knox County Mayor's Office, the Knox County Health Department, and the American Medical Response, AMR. This meeting is scheduled to last for an hour and 30 minutes. And the purpose of the reason that we are meeting is to discuss the emergency medical services contract selected for Knox County and the RFP process. This is not a voting meeting, so a quorum is not necessary. And there will be no public forum, as was previously announced on this. Anyone that would like to speak to public forum is certainly welcome to come to our workshop or voting meeting when this occurs. So we will take a roll call just for the record. Madam Clerk.
Commissioner Lundy, Commissioner Durrett.
Here.
Commissioner Oster, Commissioner Ward, Commissioner Schoonmaker.
Here.
Commissioner Hill.
Here.
Commissioner Lee. Here. Commissioner Beeler, Commissioner Daly, Commissioner Jay, Commissioner Frazier. 6 members are present.
Thank you. And I have heard from Ms. Lundy, who is going to try to make it if she possibly can. All right, we'll go ahead and begin this meeting. I see we already have someone at the podium, and I'd be glad to open it with you, sir. If you'd introduce yourself, please. The floor is yours.
Good afternoon, Kevin Parton, Knox County Health Department, and thank you, Madam Chair, for arranging the workshop. Hopefully everybody came with some great questions, lots of consideration, questions answered already, so we'll go ahead and get started. If you'll notice, I titled this our EMS ambulance contract reset. The reason for that is that it is just that. Any of us here who believe that an ambulance service can act and respond the way that they did in 2013, we are setting ourselves up for failure. So we are looking for a drastic change. So how we got here. This has been actually a process over a year now of working on this. We've had 11 contract amendments, and our vendor is actually working still in a 23 contract in 2023. In January, you all approved our contract with Fitch and Associates to come and evaluate the system. They had primary tasks, look at the current system contract, look at our performance, recommend areas of improvements, best practices, recommend and assist ambulance system design, and they assisted in the creation of the RFP as well as the contract. Mr. Vanderbeek said I had to be less than 25 minutes. So
Thank you.
Very quickly, to reinforce the things that Mr. Sheridan here came and got me my time limit, how they went about it is they interviewed our current contractor, law enforcement, fire agencies, hospital systems, 911 personnel. They did a 5-year, multi-year data request to get baselines. And then we had discussions about the current system and EMS nationwide. Anybody that wanted to have an interview was granted one with Fitch and Associates. Everybody was incredibly engaged and still are to this day. We meet with hospitals monthly now. Great progress is being made. One of the more concerning things that we did find out is EMS nationwide. In terms of staff account, there's about a 20 to 25% turnover rate in that industry. And then for 2 years of COVID, they actually didn't get to have their classes where they graduate EMTs from. So technically, they're all staffing behind at this point. One of the reasons that we're here. The RFP model design. So the goals of it were to ensure quality care, provide efficient, reliable EMS service at a reasonable cost to our constituents. Keep that one in mind, we'll come back to it. Provide the community with an operationally and financially stable system. Get an equitable response time across the entire county, and then also develop a system that's fiscally responsible. Tiered response balance. This is possibly the biggest change that we have inside of the new model and contract. In our prior contract, basically almost every call had to be addressed as a high acuity call, meaning paramedics, to everything from a priority 1 call to a decedent transport, and required an ambulance that fit that need. Overall, this creates stress on the system. The new one creates the flexibility that one needs to appropriately address 911 in 2023. Appropriate use of the correct resources at the right time. Highest priority calls will still be answered by medical first response. That's our friends and neighbors in all of our fire departments. Our lower acuity calls get triaged down to meet the lowest possible need. And then once again, not only are response times met just in the city, but they are through all out the county. It allows us, our provider, to offer virtual care, telehealth, nurse navigation, phone triage, many other things. Moving on, one of the bigger things that you'll see, I know speaking with AMR, they're excited about is the county will employ the medical director. What this will allow us to do is have a local certified in emergency medicine physician here to write our protocols, approve the protocols. Real-time data will show if protocols need improvement, enhancement. They can do clinical reviews, and they will help us develop the clinical scorecard and key performance indicators, as clinical care is now a portion of the compliance. This is being an example of what a scorecard could look like. Obviously, this one's just an example, but this is done for every single one of our calls, and then it's reviewed monthly to see how our contractor is performing. Dispatch function. Director Anders is here somewhere. There he is. He will answer all of your questions when it comes to dispatch. We do know that we'll go to a single CAD system. Technology fail points will diminish, call taking will become more efficient, and reduce over triaging of responses. Inside of our Fitch report, we found that 90% of our calls were prioritized as a priority 1. However, when they got to the billing section of that, 30% of those were billed as low acuity, meaning we sent high acuity assets to low acuity patients. Software. So we will own the compliance software used for contract compliance. This is an enormous leap forward for us. Currently, as your constituent perhaps lodges a complaint or AMR receives a complaint, it takes us several days, and Tanya from Director Anders' crew deserves a raise because she's the one that I have to call to pull all the data to verify what happened. It eliminates duplicative work. We'll get real-time response times, scene times, hospital drop-off times. It'll enhance monitoring of the KPIs. We'll be able to see demand analysis, and it'll also increase some transparency. Customer service enhancements. So the vendor will have a customer service line that's monitored 24 hours a day, 7 days a week, and requires a 30-minute callback. So what that means is if you receive a complaint, you can direct them to that line, and that's actually reported monthly to us in our compliance meeting going forward. And then patient surveys, which I believe AMR already does. However, we'll be monitoring those as well. It's a minimum of 10% of people who receive care, and it's actually done by a third-party vendor. Financial stability. This is accomplished in 2 ways. The first is rates will be set to 300% of Medicare and updated annually in January. This, according to not only our consultant, but AMR and another proposal, this is the usual and customary rate for EMS. The reason why you set it that way, especially in our area, and why this is advantageous is that no matter what you set that rate to, 70% of respondents are Medicare or Medicaid. So it's a flat rate. you could charge them $5,000 and you're going to get reimbursed $390. 20% after that is self-pay. So those will be individuals that are underinsured or have no insurance, so payment for that individual is very, very low, if any. Your final 10% are your private pay, and if you were to go beyond that, your only hope is that you somehow bill high enough that 10% make up for 90% of your calls, which would be virtually impossible. We also want, to have the control and the know of we're sending our vendor out with our municipal authority and they are not gouging at our customers, our constituents. We know that they cannot make up the difference in private pay. And this will fix a past problem of rates not increasing over a certain amount of time, putting our vendor at a disadvantage. The second, which is also not new to Knox County, but new over the past decade, is the subsidy. What the subsidy allows to do, it gives the contractor the financial stability to meet the performance needs of this contract, but it also allows them to reinvest their monies without continuing to lose funds in new innovations, nurse navigation, QRVs, ET3s, whatever it might be to improve service for our constituents. At the end of the year, if they somehow did not make money because they were penalized for response time or clinical time, that is strictly due to them. We did what we could do to make them succeed, make them profitable here inside of our county. That penalty goes directly against any profit that they would have. On to the RFP process. Your evaluation committee for this process, that was myself, Steve Hamby, who is the emergency response coordinator. He also happens to be the chairman of the state EMS board. He's at his first board meeting today, so he couldn't really miss that, just being elected chair. The director of the Knox County Emergency Management System, board certified physician in emergency medicine that practices in a local ED, and a member of procurement. So, what did we do? How did that work? So we had our initial kickoff meeting. Mr. Meyer's group very pleasantly told us that after we receive our proposals, we can't talk to anybody about anything that has to do with this RFP. And we did so very well, I think. So we had our kickoff meeting. The proposals went to committee members. We completed all of those on our own, sent those in with the first round evaluations. Procurement set up an in-person meeting. We came in, were able to speak very frankly about all the proposals, pluses, minuses, any of those things. We left, did another round of evaluations, and sent those back in. Virtual meeting was held. At that virtual meeting, procurement told us who the top two organizations were, and the committee decided to have those two present. We had presentations. Each organization had about an hour and a half, somewhere in that neighborhood, to give a presentation. We had a very robust discussion after that. We all went home, we're back to work. Final evaluations were completed, final scores were tallied, and that's when the award was made. So what did we review? These are the categories that we reviewed. So you have administration, which included leadership, strategic planning, very important human resource topic, operations, clinical services, communications, fleet maintenance, quality management, which are business results. It did include past performance. They had to submit references, which we call or Google. And then there's the subsidy. Only procurement will evaluate subsidy. The members of the committee don't do that portion of it. what did the scores look like? So in the administration category, this is kind of how that played out. Our awardee came in second there. In operations, they far exceeded everybody else in that regard. And then in quality management, they came in second again. And then when we look at the subsidy, they were first in subsidy. Interestingly enough, they gave, beyond those that gave Mr. Anders his $900,000 request, they gave the most equity for dispatch. And then overall, this is how the scores tally out, and the award was made to AMR, which I believe you all have a consolidated version of this that includes subsidy amount. With that, I'll open the floor up for questions, hopefully more for Mr. Spencer or Mr. Myers, but either way, we'll be good.
Have you completed your
I have.
summary? All right, thank you.
I think I made it in less than 20 minutes.
Thank you, Mr.
16
Parton. That's
minutes.
very concise. While Mr. Parton is here, before we go any further, I see a light on with Ms. Frazier. Commissioner Frazier?
Thank you, Madam Chair. First, I want to thank all the providers who submitted proposals. We had some really strong candidates to fill this contract, and I want to thank those that did submit proposals. I also want to thank the review committee for a very thorough evaluation. I've heard very positive feedback on the process. This is tough. This is really tough. This is one of the most important things we will do probably as a commission and a county, hopefully for many years to come. And so my questions and comments are kind of for everyone who's here representing either the recommended provider or our county staff. So, Madam Chair, would you like for me to hold off on those others? Because my questions and comments are all kind of mixed in together.
I'll tell you, before we go any further, is there anyone with the mayor's office or even, well, I'll not ask AMR yet, but anyone with the mayor's office that would like to make any type of a general statement before we go any further?
Yeah. Thank you, Madam Chair. Dwight Van de 400 Main Avenue. I just wanted to, as I think I have before at this podium, recognize the work that the staff has done here. This is a heavy lift, and the work that Mr. Parton has done, the emails and texts I've gotten from him at 9 and 10 o'clock at night are evidence of that. The calls I've put into him at 7 in the morning, and he's already at his desk, are evidence of that. Matt Myers and Jay Garrison have done yeoman's work in this. And above all, what we are asking this commission to do is trust the integrity of the process. None of us had necessarily a preference in outcome. What we had was faith in the process. We kept it dialed in. One of the things I'm most proud of is that somebody came up to me at a work session a couple weeks ago and said there have been no leaks, and I've tried. And we're proud of the fact that we worked so hard to keep the process buttoned down by the numbers, and that really is a testament to the work that the staff has done. I did not know. The mayor did not know. Nobody outside the committee context knew what the result was going to be, nor did we even know what it was until it was decided. And so, again, I just wanted to commend the staff for the work they've done.
Thank you, and we commend you also, at least as far as I'm concerned, your efforts at secrecy, for lack of a better word, were quite successful. So that does speak to the integrity that was used as we moved forward in all of this. So that is greatly appreciated. It looks like probably the key people that might be asked questions are pretty much toward the front here. So I will go ahead and turn the floor back to Commissioner Frazier, and you can just ask all the questions of these people that you might have, and then we'll move forward.
Thank you, Madam Chair. I first want to say I felt very much like I was back in college. I did read everything. That includes proposals, proposed contracts, the Fitch report. I'm sure we've all received dozens of emails. I have heard from peer agencies, emergency response agencies. I've heard from constituents. I've heard from folks serving as physicians or nurses in the county. So I have thought a lot about this on very little sleep, especially the last 3 or 4 days. But anyway, I'm just going to go through. Some of these are my opinions, my comments, feedback, questions. So everyone just bear with me, and I'll just kick us off here with hopefully some really good discussion. So first, over a decade, we've had the discussion that the county's current model for emergency services isn't sustainable, and for a multitude of reasons. So we have a real opportunity here and a real responsibility to get this right and bring everyone to the table. I also understand the logic about excluding KFD numbers in the Fitch report. Respectfully, I don't agree. I would have liked to have seen those numbers. I also feel like we have a responsibility as a commission to address long wall times with our hospital executives. And I reached out to them today and requested dates and times for this commission body to visit and have some on-site tours and talk to those folks because, I feel like we owe that to any provider that we select. So we're doing that because, I think I likened it to we're kind of playing baseball without a catcher. So we need that information. First, I want to say that respectfully, I am not comfortable with the response times recommended. Again, I've spoken to dozens and dozens of people. And on a personal level, the thought of my child waiting in an emergency situation for 20 minutes, it gives me great trepidation. Patients in cardiac arrest without care, they're dead in 4 to 6 minutes. Arterial bleeds, 3 to 4 minutes. 20 minutes is hard for me to stomach. Even though we do have paramedics who are quick response, and I think that's sometimes confusing when you talk about response times because the response times we're indicating, that is just ambulance transport. That's not care being given on site. And usually there's a quick response vehicle with a paramedic that is there before a transporting ambulance is. So I want to make sure everybody kind of understands that. But what I would like to see is a response time set at 10 minutes countywide for all priority 1 calls. In addition, I would like to see more zones. And with more zones, that means more ambulance, more staff. Whatever it takes to reduce response times and ensure the availability of emergency responders across the county, I think we should do it. I know we've got to pick an ambulance provider. I just want to make sure that in this contract, we have identified ways that we can, or that our provider can subcontract out services or programs, that they can add additional zones and ambulances and staff. They can carve out specific services or programs if they need to, and that they look at mutual aid agreements both within the county and our surrounding areas. So those are some general comments. To the references, how many references were contacted, and were they of similar models and population?
I contacted 2. I don't know how many of the rest of the committee did.
So you left that up to each individual committee member?
Yes, each committee member had their discretion as to call. Like I said, you could also find out just an enormous amount through the internet. It's all in the news everywhere. And then almost all references, their models were included inside the proposals.
Okay. And then I would like to see some of the patient feedback surveys from our recommended provider. Also, I would like for a provider to implement peer emergency response agency surveys. I think that's important when you are looking at collaborating with other emergency response agencies, that they kind of communicate with each other how they think you're doing. I would like to see that included as well. Also, question, why weren't financials weighted in the process? I just feel like the financial health of a company is very important.
All reviewer 3 of the 4 proposals had financial data, and the reviewer could use those at their discretion.
Okay, but those were not weighted.
They were weighted according to how the reviewer felt.
Okay.
So, for instance, if I reviewed one and it was subpar, I looked at that as either operational or perhaps a leadership or administration thing.
Okay. And then to the recommended provider, I'd like to know what your cash reserves are, and do you have cash to fund expansion if it's needed? Introduce yourself too.
Sure.
Please.
Hey, I'm Brett Jovanovich. I'm the Regional Vice President for Global Medical Response and AMR. And to my right is Josh Spencer, who's the Regional Director of Operations for the East Tennessee market. So, Commissioner Frazier, I don't have those numbers at my fingertips, and I'm certainly not the resident financial expert. I have talking to our GMR CFO, and he's more than willing to schedule time to meet with any of you or individually via phone or in person for those more detailed questions.
Do you have a general answer do you have the cash on hand to fund any expansion?
Yeah, absolutely.
Liquid cash?
Yes, ma'am. Sorry. No, GMR continues to grow and expand. We continue to be a solvent organization that looks for opportunities. So yes, absolutely.
And then for the county, go over a little bit about the $1 million performance bond.
So what that allows us to do is if our awarded provider cannot provide service to our needs, we can give a 120-day written notice to terminate, use our performance bond to temporarily stand up service while we go through this RFP process again.
And then AMR, you noted in your proposal that there wouldn't be additional operational costs, startup or additional operation costs. How is that so if we're not adding services and additional ambulances and staff?
Sure, absolutely. I think one of the benefits of being the incumbent provider is that we've already got the required number of ambulances. We've got the equipment necessary. I think it becomes getting us into the new formation of service delivery. We know that this new contract going forward is very different, embracing innovation, tiered response, where we're adding additional EMT level ambulances, advanced level ambulances, paramedic level into the system. And so for us, the initial startup cost is not as significant as it would be from someone from the outside. Quite frankly, we don't necessarily have to wait until February 1st to begin to implement the changes. It's something that we can continue to use the current resources we have to get to the right formation under the new contract.
And then another question. Thank you all for your patience with me. I have lots. I know you're shocked. Will the sale of rural metro impact your services or the day-to-day operations?
Yeah, from a GMR perspective, that's not something that we comment on related to any pending transactions, contemplated transactions. I would just share that it's been my experience that there is no interruption to day-to-day operations in those scenarios.
That's really my question to you, is that if a new buyer were to come in, can we trust that the same process would be in place if there were amendments or changes requested in our agreement? And I believe the answer is yes.
Yes.
Okay. Has Knox County ever considered fining hospitals for excessive dwell times?
I would have to direct you to Director Book. I don't know that we have the regulatory authority to do so.
I was just looking at the Emergency Medical Treatment and Labor Act, which requires hospitals to have specific requirements of their emergency departments. So that may be something that we can have that conversation with those execs when we take a visit to see them. I talked about zones. We talked about mutual aid agreements. Would you initiate mutual aid agreements, and do you plan to subcontract with other agencies if the need arises?
Hey, Josh Spencer, Regional Director for AMR. The short answer is yes. One of the things I really like about the new, and as Kevin mentioned in his presentation, the unified medical direction I think that's going to really help bringing everyone together more as a team and a consolidated and a collaborated approach. So we already have mutual aid agreements externally, I think, with other counties and neighboring counties for events where we need to reach out for mutual aid. And likewise, we also respond to other counties occasionally to offer them mutual aid. So that will not change. But internally, I think is more your question with other agencies, the fire departments and police departments, and certainly believe that the unified medical director will certainly get us all kind of in the same formation. And so, but a formal MOU, yes, we can get there. But I think the clinical appropriateness of having that unified medical director will certainly guide that conversation.
And then talk to us a little bit how you will address long hospital wait times, recruitment and retention, performance requirements, insurance reimbursement challenges, because I know there are lots. And then looking at shifting away from zero level. And Kevin, if you can take a minute and just explain, because I think that's also confusing to lots of folks of what an actual being at zero level means.
Sure. Level 0 is a readiness term. You won't find it in the new contract. It's kind of expired in its use. But what level 0 truly means is that at the moment a call comes in, there is not an ambulance available to directly go. That doesn't mean that the ambulance does still not get there in 10 minutes, 20 minutes, or whatever the baseline is. It just means that that one moment in time, there wasn't an ambulance available.
Thank you. And then would you guys talk about like the long hospital wait times, recruitment, retention?
Yeah, I'll take the first stab
Sure.
at that one. Brett may have some comments as well, but for long hospital wall times, we've talked about this for a while. This is not uncommon in the industry and certainly not in Knox County, unfortunately. I guess my first comment would be the health department and Steve Hamby, who's not here, Kevin, have really worked hard on establishing a healthcare kind of task force, which brings all the partners together. We're starting at this point really with, I think, the ambulance provider and the hospitals and having conversations about what can we do to help solve this problem. We've talked about it before in front of this body. We currently are surging. We have one crew watch 4 or 5 patients if they're not critical. When we're doing all those things now, but I think that healthcare task force really gets us some more consistency with some of that, and I think it allows us the opportunity to have more candid, direct conversations about how can we solve this problem. Additionally, I think the best kind of medicine, no pun intended, is really preventive and diversion out of the hospitals, that those that do not need to be there to begin with. I think that's the best cure, if you will, for the hospital wall times. And one of the things that obviously I think was very well established in the RFP process and in our proposal is some of those things we're doing to divert patients out of the ED who do not need to be in the ED for that very reason. So I think that's the most important step, is the diversion tactic. But Brett, do you want to take on the recruitment retention question? I know you got some answers there.
Sure. Does that answer your question, Commissioner, on the ER wait times? Mm-hmm. Okay. Recruitment and retention, I believe, was your next question.
Yes.
No, absolutely, probably without a doubt, the biggest single strain on the EMS infrastructure across the country right now. I think it was well articulated by the consultant, and I think Kevin mentioned it earlier in his presentation. We've seen unprecedented, we being the EMS industry, has seen unprecedented turnover and recruitment, lack of recruitment since the pandemic. Wage pressures to recruit and retain workforce is at an all-time high. To think just back 5 years ago that we would be competing with retail space or other industries for workforce would have been unfathomable. But that's the world we find ourselves in today. Couple that with the insurance reimbursements or their lack of, where we know that governmental payers are reimbursing at or below the cost of providing the service, makes it extremely challenging to have competitive pay. And so we address pay within our financial model here in Knox County. In addition to the wage adjustment that we put into place in 2021, we also contemplate an additional wage adjustment as part of our subsidy ask, factored in to be able to give a sizable wage adjustment across our workforce. That was factored into our financial model, which drove our part of our subsidy ask. In addition to that, and we've implemented this probably over the last 3 or 4 years, is our Earn While You Learn program, where we market civilians within the community that want to serve their community. We pay for them to go to school, we pay for their schooling, and then we offer them employment on the other side of their certifications. I think typically on an annual basis, we graduate about 50 or so of those brand new EMTs into the market to serve the Knox community. The challenge is we got to keep 50 from leaving the industry as well, and it's not all competitive pay. Oftentimes it's burnout and exhaustion in a very rapidly changing and stressful environment. And so we spend a lot of time on the mental health of our employees. GMR has an entire department, GMR Life, that focuses on the mental health and wellness of our employees. And so we really have taken a holistic approach to recruiting and retention. I would just say that as we think about sort of the next evolution of the Knox partnership, having served the community as long as we have, are there opportunities for us to partner better together in the community in terms of recruiting and retention? We know that first responders, people are turning away from the industry, whether it's fire, law enforcement, EMS, people are turning away from the industry for lower stress, more flexible hours, higher pay. Is there opportunity for us to collectively partner together to have recruiting efforts across all first responders and encouraging our high schoolers, encouraging our technical colleges and other members of the community collectively to come serve Knox County as a dispatcher, as a firefighter, as an EMS worker, as a law enforcement agent, really see an opportunity for us to work together to bolster up that recruiting effort.
Great, thank you. I shouldn't say we, I've received just several emails and comments, and I just would like for you to respond to these statements, if you would. These are just some of the things that as a commissioner, that these questions have been posed to me and asked if I would ask you all. So on behalf of my constituents, I'm going to ask. Why didn't you address these concerns with the current contract? And how can you convince me or Knox County that it will be different this time?
No, absolutely, and I think it's a fair question, and what I'd like to do is sort of unpack the history in sort of 3 buckets, if you will. The first bucket, I would say, would be the contract dating from 2013 to 2020, and I think if you go back and you look at our performance driven by the leading indicator of performance penalties, I want to say we were less than $30,000 or so annually or over a period of time. Which would lead me to believe that our performance under the traditional contract was at or where it needed to be. The next bucket would very much be the pandemic bucket, right? This is 2020 to 2023, and we'll certainly own that the situation and the challenges have certainly impacted the EMS system, and it's been very much a surviving dynamic of how many ambulances can we get on the road with lower staffing. Many of the challenges were outlined in the Fitch report were things that were not necessarily caused by anything AMR directly did, anything that the county directly did, or that the city directly in. It was just a product of the new environment that we're currently operating in. And so that, I think, covers the challenges that we've had over the last 2 or 3 years. And certainly we feel like we continue to work extensively, whether it's our implementation of the nurse navigation product, wage adjustments, telemedicine components. We have attempted to solve some of these challenges. I think as the third bucket comes along in terms of the next evolution of our agreement, I really see this as the turning point. This is the next evolution of embracing innovation. I think the traditional, decade-old contract did not reflect and reward, if you will, some of the innovation, whether it's the tiered responses of getting the right patient or getting the right care to the right patient at the right time. Certainly I'm excited that clinical is now a major scoring component. I think at the end of the day, we all want to feel comfortable that constituents that call 911 end up in a better scenario after accessing the county's 911 system than they did before. Oftentimes response times don't tell that full story. It's really the clinical dynamics on the back end. And so we obviously applaud the county for leveraging clinical metrics into the measures going forward. I would also say, in addition to all the innovation and the diversion strategies of keeping unnecessary patients out of the emergency room, leveraging telemedicine and the ET3 and the Nurse Nav and some of the innovative products that we have that will continue to develop, is really cultivating better relationships with our peer agencies. I'm certainly mindful, and I think Josh would articulate, I feel like we've operated in a world where there's a number of dotted lines across multiple agencies, whether that's law enforcement, fire department, AMR, hospitals, so on and so forth. Feels like under the next contract, there's an opportunity for us to bring everyone together to the table to solve, what I call the next evolution of EMS in Knox County, which involves everything from Mr. Andrews' 911 call, from the time that call comes in, to whether or not the acuity shifts to nurse navigation, whether it shifts to fire department first response, to AMR first response, all the way through the hospital. It's that entire patient experience that I think we collectively have to come together to solve. I think those challenges that were articulated in the consultants' reports don't magically disappear overnight because we have a new contract. I think it very much will take all agencies coming together collectively in full transparency of information, full transparency and alignment and direction, to ensure that we're all aligned in service level delivery and expectation going forward.
Thank you. Let's see what I've got left here. Director Parton, how much will the operational software cost the county?
Estimated around $200,000 to $250,000 annually.
Okay. And then have you determined who will be on the oversight committee?
Not as of yet, no.
Okay. And then to AMR, how many staff members do you anticipate that are needed to fulfill the requirements of the contract? How many ambulances, and then how many reserve ambulances?
So as far as staff members, we feel like we're probably in the neighborhood, depending on our deployment model, which we're still kind of trying to flesh out, probably around about 115 to 120 full-time clinicians, between EMT, basic, advanced, and paramedic. And then with that, we believe, based on the Fitch report and some of our knowledge of the system and our history here, we'll probably need to be somewhere around 20 ambulances a day, kind of at a peak, to accomplish that. As far as the total number of vehicles we have approximately 45 to 50. I don't really know, the number fluctuates from day to day, of vehicles here in Knox County, ambulances in Knox County, largely for, the reason why we have to have so many, although we only deploy 20, our staggered deployment is intentional. So when you deploy a truck at 6 o'clock and another one at 7 and 8 and 9, as it kind of rolls up to more of a peak level, you have to have multiple vehicles, so there's, they don't have to wait on their partner to get, or their other truck to get back so they can get in the service. So we feel like we certainly have that ability to meet the demand. Our staffing, again, is right now, we have about 160 or so clinicians currently. Not all of those are full-time. We do believe that some of our more aggressive wage scales, more desirable shift types, things of that nature will start to draw employees back to Knox County as a full-time employee.
Thank you all very much.
Commissioner Lee?
Thank you, Madam Chair. My question's not for AMR, but I guess Mr. Parton. One of my big concerns about this is it doesn't matter how fast the ambulances respond. Is when patients get to the hospital and it's taken them 7, 8, 9, 10, 11 hours to see. And, we've heard about the shortages, but are the hospitals at this meeting, are they not answering to why the wait times? Because I have family members that work in healthcare, nurses, doctors. They're on the front lines. And there's a lot of empty beds at the hospital. But there's plenty of office space, admin. We don't hear about admin being short. What are the hospitals doing to basically show up at the table and do a better job of less time at the ER?
I will hesitate to speak for all the hospitals, but from the meetings that we have, you see a lot of empty beds and and that is very true across the system. They're working to create what they call their own, very similar to our friends here, pipelines with University of Tennessee, LMU, all of those that are graduating clinicians on a regular basis to bring on more staff faster and better.
And that's great, but I want to talk about the healthcare, the nurses that are leaving because they're not being compensated. If you run off the people that have been there 10, 15, 20 years because you're not paying them the same as what people who are brand new, how is that being addressed? Because that's happening.
I can't speak to the hospitals for that.
Okay, and I know you said that we can't fine the hospitals, but what actions can we do to the hospitals to make sure they're doing a better job at taking care of patients?
I would have to direct you to Mr. Book. I don't have any regulatory authority over hospitals.
Okay, thank you.
Thank you. Commissioner Jay?
Thank you, Madam Chair. Thank you, Mr. Parton, for leadership in this process. I understand the hard work. It's a big task. This is a massive thing to tackle. A lot of work went into getting us to today, but I still think we have a lot of work to go. I do appreciate, I spent a lot of time with you and Mr. Vandevate looking at the RFP, looking at how we're sort of improving the mousetrap, if you will, and I think there's tremendous improvements to where we're going. I think we're going to have to do that constantly over the, every 3 to 5 years. If you ask me what 2013 looked like, I couldn't even fathom it. But it also, there's a really important process before us to pick the right partner and to make sure that we're doing the best thing we can for our constituents, because it's been a rough few years on everybody. And arguably, I think you all have said it, it's been a rough few years with AMR. And you have to own some of that, too. The system has to own it, but we can't just constantly blame everything on COVID and just say that's the issue. We all have to get better at either how we design it, how we implement it, how we execute on it. I still think there's a lot of work left to do, but I want to get into some specifics. Where did the data come from in which everybody based their proposals on?
How did we get the data for the RFP?
Yeah, the number of responses, number of calls,
That came directly from the CAD at 911.
From the 911 system or from the AMR as the provider?
AMRs.
So from AMR system.
Yes.
Did anybody verify? We assume they gave everybody the exact data. Did anybody verify it, go through it? What I'm getting to is I want to make sure everyone got an apples to apples comparison when they were doing their bids. Or was it just assumed that everyone was given? We're asking I'm going to play devil's advocate on a lot of these questions, so I'm not saying any of this happened, but I'm just sort of thinking through the process. You're asking a current provider to give data, everyone else that's going to bid against them, data, and then assume that everyone's on the same playing field.
So the data that the proposers used, what came out of RFP, which Fitch created all of that data from the 5-year pull at the beginning of their process.
Okay, so Fitch had access to that data directly.
That's how
Okay,
yes.
All right. Is there an extension contract already in place with AMR should this process take longer than the current timeline? I think Fitch told everyone early on in the process that the February deadline, I think even some of our procurement folks said that the February deadline it's tight. Is there an extension contract currently in place?
There is not.
Why was that not done before he started the RFP process?
It was done as we started the RFP process. The contract actually effectively ended last June. We extended it through February in order to get through this process.
Okay, so what happens if this process takes longer than that?
we negotiate and ask our current provider for an extension.
Okay, so we're in an extension currently.
We are currently in an extension, yes. The contract ended its second term. It was extended once after the initial term in 2013. So
Okay, so the contract went through June
30,
30,
yes.
but we were right in the middle of the RFP process to even build it.
Yes, we extended this last year.
Okay.
During the holidays, there was a very confusing language that the mayor had to come to commission, tell him that we were not renewing the contract or extending the contract another 5 years. During that time, we actually went through the approval process for Fitch, and then on the same, almost.
Yeah,
the
I
same
remember it being
agenda.
confusing. It was like, we're
Yes.
canceling this, but we're also throwing that out, but we're going to
Yes.
reissue that, and we're going to
Absolutely.
extend this while we do that other thing.
Yes,
Okay.
so we did all of this last year.
Well, why didn't we leave a longer lead time in all of this? I guess these things take time. I get it. It's time, it's committees, it's review, it's structure, it's process, whatever. I feel a little crammed in the corner of, you got to make a decision really fast in a short amount of time, or Knox County may be in trouble. And is there an assurance from our current provider that if it does take more time, that they're committed to Knox County?
I have not had that conversation with them yet.
I guess I'll ask that to you.
That has not been contemplated or asked to us, so that would be something we would have to formally sit down and have a conversation about.
Okay. When I look at the selection committee, one of our largest, arguably our largest partner in county government is the city of Knoxville. And they are certainly the largest, arguably the largest, their constituency is ours, of course, but it's a massive customer of this. Why wasn't the city of Knoxville, the Knoxville Fire Department, or somebody key in that constituency group that does operate a municipal fire and works so closely, why weren't they part of the selection team?
If we were, that's a great question, and one that we struggled with greatly. It would have been very difficult to bring on one of our fire partners and not bring on all of our fire partners.
But some representative of that emergency services world, certainly their perspective in grading and picking the next person they're going to have to use as well.
Right. And
Should have
that's
been pretty.
And that's the reason why we asked and Colin Ickes, who serves both the city and the county, was brought on board.
Okay. Can you just broadly explain this grading process? Like, first off, was the scoring relative to others, or were they scored on their own metrics individually? Like, were the evaluators going, okay, I'm going to score this one in a silo and then I'm going to stop, or were they kind of comparatively?
Comparatively.
Okay. Can you, administration, operations, quality management, and subsidy, like, can you just broadly explain those four categories for us?
Subsidy, I'll start there just because it's the simplest. It's the 5-year total of the contract. Now, we'll have to ask Mr. Myers how they rank that, because that's a formula-based that I don't know.
Okay.
The only procurement does cost. So inside of administration and leadership, we looked at those that would actually be here managing. We looked at corporate management. We looked at strategic planning. One of our proposers, unfortunately, that didn't make it, actually didn't have one, so you automatically take points away for that. And then human resources, how they treat their individuals, how they hire, programs that they use to recruit, earn as you learn, military bridge, things of that nature. So that's what was in your administration and leadership bucket. In your operations, we looked at clinical services, focusing a lot on not just the term you call, we haul, really what's innovating about your particular organization. What are you doing to, as they said, divert individuals that are not as sick as they are away from the hospital to keep them from waiting hours and hours and hours at a time. Communications, it worked with Director Anders. How will they mesh with that? What do they put on their vehicles for location devices? What equipment do they use as radios? All of those types of things. And then medical equipment. So if you were to look at a proposal, they all listed all of the amazing equipment that goes on each one of their ambulances. So you have the very similar characteristics there. Quality management, that's your customer focus, business results, information, and analytics. Really interesting part of this, that's where they send their references in. Very much like those that if you were to be applying for a job, they don't send the references that would say something bad. Hence the reason I say Google. Customer market focus is what's their community engagement? Are they out recruiting? Are they out giving classes, CPR, things of that nature? Information and analysis, do they use data to drive their decisions? Really big portion of this is going to be your QI, QA programs. Do you have one? How often does it meet? When will it meet? Here in Knox County, we want a monthly one. That's where we're going to bring in all of our first medical responders, city, fire, all of them. Sit down and talk and see what's going on. County medical director leads the way, making sure everybody is on the same page. And then certifications, if they're certified by another ambulance certification service.
It's an interesting, there's a couple of elements that I don't think were included here that should have been, but I wonder, like, past performance should be one, but you've only got one of 4 that you've worked with for 10 years. So it's hard to compare the other ones, of course, unless you looked at, their performance in other markets. Was that ever a discussion of how do you again compare, 4 bidders on performance when you only have one that
Sure.
you've actually interacted with here?
Right. So they all submit references and they all submit those that are large enough. I will say we were lucky enough to have the 2 largest providers in our nation actually bid on our services. I think that says a lot for our county. But they all submit references and contracts that they have with a number of people, populations, things of that nature. And so that's a very easy way to see who is already in the space that could handle 526 square miles, 500,000 people at any given point. So that's another way to do that.
Don't go very far, but Mr. Myers, could you break down the 4 subsidy levels? I have them in each of the proposals, but it'll help me just write them down on this real quick.
Thank you, Madam Chair. Matt Myers, Knox County Procurement. I don't have the subsidy numbers in front of me, I'm sorry, but all it is a mathematical formula.
Not how you graded them, what the total was, like per year. You got AMR, was it how much?
This is a 5-year. Yeah.
Not the total over the contract, just a per year.
Yeah, he's looking at per year, Kevin. We've got a 5-year, you're handed a 5-year subsidy number. We can get to a 1 year if that's what you're looking for.
Or 5-year, whatever.
5-year was 11 million.
11 million for AMR.
AMR,
And Maripro,
12.6,
Falk,
20,
and Priority.
16. These are all millions.
And that's for a total of 5 years. Okay.
That's 5-year total.
All right. Thank you, Mr. Myers. This goes back to, well, I have two related questions of elements that were not in the grading. Did the selection committee look at or ask any information about staffing levels, current, past turnover rates? How do you determine the health of an organization with their people and their ability to manage people? I mean, if I see a company who says I have 160 people today, but they used to have 450, then, that's a different discussion if they had 180 last year and 160 this year, Was there any of that consideration of sort of what's the health of their workforce?
That's covered in that HR portion of it. There were no, or at least I do not recall any specific questions of how many people are you currently staffed with.
But you didn't really dig into like how healthy are they as an organization?
We see, through the proposals, we see what they do to maintain the health of their employees or create a workforce environment that they want to be in.
Okay. And I think Commissioner Fraser touched on this earlier. Why wasn't the fiscal health of each company, weighted in a way that was, almost a separate category? Because to me, that's a huge deal. If we're about to pick a provider, we need to make sure they're financially solvent, A, have the resources to invest, B, and have a prospect for a healthy company in the future, C.
Sure. So it's a good question. And I would say there's no single way to determine that. So while you might consider net income the driving force to how healthy an organization is, Commissioner Fraser might think EBITDA is more important. So if you two are on the evaluation committee and we have it as graded weighted financials, you could give them a 0 and she could give them a 300 based off of a single number.
Yeah, but I think you could, debt would be one, EBITDA would be one, sure. Balance sheets, cash on hand, credit rating. There's got to be 10 things that every company, I read all the proposals, sure. I read all the financials. I worried that was not a bigger part of the process. And I'll get right to my question, which, to AMR is, I gotta say, I'm incredibly concerned about the ability for AMR to be a partner to Knox County, given the financial health of, your own financial statements talk not only about, liabilities and lawsuits and things, operational things that everyone has, but, your credit was downgraded. The amount of debt that is coming due in the next 2 years it's astronomical. You're owned by a private equity firm that, is known for driving profits, and when things are going south, sell off assets like Rural Metro and other ambulance companies have failed under their ownership all over the country. Help me understand why with $5.4 billion in debt coming in through in the next 2 years, a private equity firm that's selling assets, a downgraded credit rating, and huge financial pressure, you're going to have the ability to not only be sustainable, but invest in Knox County.
Yeah, Commissioner Jay, I would just offer the same thing that I mentioned to Commissioner Fraser. If you want to have a conversation with our GMR CFO, he's more than willing to get on the phone and answer those specific questions. I will tell you that the financial models that we have run for Knox continue to be sustainable on the go forward. I don't think it's uncommon for an organization our size that has large capital in terms of ambulance equipment, aircraft, technology, to have substantive debt. I will tell you that our CEO, Nick LaParaca, who just came on board in June, has known related to the debt service coming due in 2025 and has, obviously positioned us well to handle that. I don't think that's uncommon for any industry, quite frankly, in the new environment where you have large wage pressures, you have large inflationary cost pressures. I don't see that as anything different than what other industry is experiencing at this point. But again, if you've got specific financial questions that you want to unpack, Brian,
I will follow up, and I think we have a meeting next week, so I'll be happy to send those in advance. In Knox County, we spend a lot of time with our finance department and our investment committee and our finance committee. We talk about our bond ratings, we talk about the cost of capital. We spend a tremendous amount of time sort of making sure that we're in the best financial position. And I'm literally reading from the S&P report. This is not a third party. This is literally the credit rating agency, and it is dire. Their report says GMR, your parent company, is in terribly dire situation and without a rosy outlook. And you may not be privileged to this. Look, you guys are in the trenches in a local level, and maybe this is up for somebody else, but I think it's going to be critical at some point from AMR to convince this commission that you are going to be financially solvent and have the ability to invest resources in Knox County over the next few years without us worrying about A, being sold, or B, being bankrupt. And so I think that's a huge, I think that needs to be answered by somebody. I'll follow up with a specific. Mr. Parton, why was the reimbursement rate capped at 300%? You mentioned it quickly, but at the beginning, but help me understand that. I can understand Medicare is going to pay what Medicare is going to pay, so it doesn't really matter. That's the federal government. I understand that private self-pay or people that are uninsured, that may be an excellent way to cap certain is. But why would you cap the ability for a private entity to bill another private entity, such as private insurance? If I've got really great insurance and I take a helicopter ride, I've tripped in the Smokies, and they say cost of this is $15,000 and my insurance is willing to pay $15,000, why would you cap it? Why would you cap those rates?
You'd be looking at an equity at that point where you're charging so few people so much more money that it still will not recoup what they do not make out of the other 90% of all of their calls.
But you're limiting their ability to even do it. This is what I don't understand. You're giving a break to insurance companies that are, by theher own right, like of all the companies and industries that are booming right now, insurance seems to be the one that always is booming. I guess I'm really philosophically trying I am a free market enterprise champion. Our mayor is a free market enterprise champion. Over and over again, he has said, government should get out of the way. But we are literally putting in our contract, our private entity is a restriction set by the government between two private entities. It just seems totally antithetical to like the philosophy of getting out of the way and letting them. Wouldn't our subsidy be lower if they were able to bill more?
That's on the assumption that they're able to collect more. Billing does not equal collection.
Well, still, if you say you can only collect 500 and you don't give them a chance to collect 700, I mean, it's all the same to me. Why would we cap the private market? And maybe we're stuck and it's just going to be a difference of opinion, but that's the part I can't understand. If we allowed them to bill what they wanted to private enterprise and work that out between my insurance company and them, we would have a lower subsidy. We would not have to use as many tax dollars to supplement the service.
Let me fill this one, Commissioner Day, because we had long and deep discussions about it. But one of the things that I think is important for this commission to remember is when you execute a contract with a vendor, you essentially convey to them municipal authority. They operate under authority of Knox County as the exclusive provider of this service. So heaven forbid, Commissioner Lee trips at home and breaks an ankle and it's an open fracture and she needs a high acuity ambulance, an ALS ambulance. She picks up the phone, she calls Director Zander Center, and she says, I need an ambulance. She doesn't say, I need a Falk ambulance, I need a priority ambulance, I need an AMR ambulance, or I need Commissioner Schoonmaker's new ambulance service. I need an ambulance, and she's going to get the ambulance that we send her. She has no say in the matter based on authority that's conveyed to them under this contract. One of the reasons we felt strongly about capping it, in addition to the fact that it does represent the industry standard and it is usual and customary, is that we do not feel comfortable sending somebody out with blanket authority to set charges based on unilateral or business-driven assumptions. It's just too open for us.
But isn't that the market? Isn't that the free market? I mean,
If it's a free market, you'd call and pick whatever ambulance you want, sir. But it's not a free market. You're going to get the ambulance we send you.
okay, I guess I understand that part of it. I think that we're stuck in that in some way that, yes, we're sending you what, I don't know, I'm stuck on that one. I think it's really difficult because would you agree if they were able to collect more money, we would have less subsidy?
I would, but I also agree with Mr. Parton's point is that this does create some interesting issues. Do you simply send the vendor out to bill whatever they can from whoever they can? So if they go into the Mission District and they pick somebody up and that poor soul has $20 in his pocket, they collect that $20, they come to your house or my house, we have good insurance, and they collect $9,000. That's problematic to us. We think there needs to be some structure and consistency in the system, and this is the way to give us that structure and consistency in the system. This was a tough one, though. We did wrestle with this quite a bit. It's a complicated
But we do that with our
question.
fire service. We allow, we essentially say for the 20, 30% of the people that have subscription fire service, we're okay with you subsidizing everyone else. They're going to show up anyway. They get a different level of bill, but they're holding the share too.
They do, but interesting question. They actually don't operate under a contract with Knox County. One of the things we hope that comes out of the eventual new ownership of Rural Metro is we feel very strongly there should be a contract with Knox County. But currently, Rural Metro operates within the district that is approved by the state and reaffirmed by this body every 3 years. But there is actually no contract between Knox County government and Rural Metro Fire. None exists. And in this case, there's absolutely a contract, and that authority comes directly from this body.
Okay. All right. Thank you. I'll move on from that. I just have one last statement. I'm going to give the floor up to other commissioners. I know we have a lot of questions, and I appreciate the time. There's a question for our provider, AMR. Several years ago, I can't even remember when it was, but I think it was pre-pandemic, and then again during our pandemic. AMR came to this body and made assurances. We will do better. We will have more rigs. We will have more people. We will do better as a service. Right now, constituents that I talk to, the vibe in our community is, I'm not waiting on an ambulance because it takes too long. If I can throw somebody in a car, I'm going. And I think that I hear that feedback from our first responders as well, especially our police and fire. You don't have to answer this right now, but at some point during this process, you're going to have to convince this commission. How are you going to do better if we give you another shot at it again and again? I mean, you've been the provider for 10 years, 11 years, 10 years. And you've made many assurances that haven't come to fruition. How are you going to do better? How are you going to be the provider that we can count on, that our constituents can count on? Because if the vibe in the community that I get the feedback from is it's not worth waiting, then we have a huge issue. You're happy to respond, or if you can do that later.
No, absolutely. Happy to follow up and provide more detail. I will tell you what we're comparing is apples to oranges. This contract is materially different than the traditional lens that we've been looking at. It focuses on innovation. It focuses on better efficiency and utilization of the system. And as I mentioned earlier, it's removing the dotted lines of multiple first responders within the community, not necessarily working together. I see that opportunity really manifesting itself in this new world, this new agreement. We're very confident we can operate because it is a completely different world under this new agreement, right? It's innovation. It's all the things that the 2013 world was not, that the 2023 world is. I will tell you, I think the other thing, and we spent some time and articulated in our proposal very much, is community outreach and education. I think there needs to be significant dollars invested in educating the public on the appropriate utilization of 911. If that's ad campaigns, if that's other things, AMR continues to be committed to quarterbacking that. But when you look at the detail of the utilization of 911 for true non-emergencies, the numbers are pretty staggering. And so if we could do a better job educating the community on the appropriate utilization of 911, what to expect when you call 911, from the time they call 911 to Director Anders' 911 center, to our nurse navigation triage line, to telemedicine, really working collectively together and educating the public. That is where we see the opportunities in what I'll call the Knoxville 2.0. It's really embracing all of that innovation that historically was not embraced from the 2013 contract.
And I'm going to just ask one question since you've already addressed this. And while I'm asking it of you, Mr. Parton, Mr. Anders, would you please come forward? Kevin, did I hear you make the statement that, did you say 70% of the calls that were originally coded priority 3 were in fact ones? Is that what I heard you say?
Sort of opposite of that. And so they coded over 90% of their calls as priority 1s, and actually 30% of those were actually low acuity.
Were actually priority 1?
Priority 3s.
Oh, all right. So we definitely need some help in that.
Yes, and hopefully Director Anders can speak more to how that works, but really goes back to that, making sure we have the right people giving the right treatment at the right time.
Yeah, and I would like to hear from Mr. Anders as to, since you will be a new player in this, so to speak, what might be different, what might we expect?
Well, I think with the new contract comes the new medical direction, which will change the questions somewhat. It'll change the opportunities for people to get a priority 1, 2, or 3 call, right? We'll hopefully change that number from 90% down to where it should be. And I don't know where it should be, but there's multiple studies nationwide. I think Houston was one where of all of the calls that they received, only 2% required life-saving treatment on the scene. And so, 2 to 5%, something like that. But what it's going to do for us as a community, I think, is, Richard and his team of that operate in our building currently, they do a great job. There's no question that they're passionate about community. They're passionate about the work they do. They've been great teammates. But currently we operate on 2 technologies on the phone system. We operate on different radio systems. There's a lot of fail points in those technologies, and we want to eliminate those. We want every 911 call. And when I came in 4 years ago, I mean, this is nothing that snuck up on Richard or snuck up on us. I had told them in our next ambulance contract, I wanted to ask that we did the dispatching just for continuity of service and public transparency. And so once the contract was rebid, we requested the mayor's office on several occasions, several meetings, and going back to what Larson J said about the fire department not being involved, we spoke to Fitch. We, as 911, spoke to Fitch 3 or 4 times. He came in, he got into our CAD system. He was extremely knowledgeable about how to go and find the things he needed to find. I think all the fire departments had the same conversations with Fitch, and them not being part of the grading process was one thing, but we were all involved in the beginning of that Fitch report. But what it'll do is for the community, allow us to answer the call and dispatch the call. And it's on one set of technology, it's on one set of employee groups. There'll be, like right now, if there's a complaint about EMS or response to anybody, they call us and them. That will eliminate, this new contract will eliminate, if adopted, will eliminate that. It'll be one-stop shopping for anything 911 related.
Will your dispatchers be trained differently from the ones who currently are dispatching ambulances?
No, I think some of the same services will be in place, Nurse Nav and everything that they're providing as a service. We'll just transfer those calls to Nurse Nav just like they do now. We hope to interview and train. They're all going to be APCO certified just like they are now. They're all going to be trained on what the medical director advises on the protocols. We hope to interview some of their employees if they downsize or give their employees opportunity to come work for us because they are very good at what they do. And along with that process, we're going to have to, we're inheriting Rural Metro and Seymour dispatch at the same time. So we've got quite a turnaround to perform between now and February the 1st. And so and as I anticipate, Richard will work with us well in that transition. The community will not be left behind because we can't get equipment in or things like that. The equipment's already in the room, that's theirs, and we'll work through that. But we're going to have to spend of our dollars, of 911's dollars, we're going to spend up to close to $500,000 to make this happen before February. So this is no small task for us as well.
Thank you. And would you give your name and address for the record?
Brad Anders, the Executive Director of Knox County 911, 605 Bernard Avenue.
Thank you. Thank you. Commissioner Oster?
Thank you, Madam Chair. I want to start with a couple of things that I like about this. That might be, change it up a little bit. First of all, the thing that I really like to see that Director Anders and his staff was going to be involved in this. I have the utmost respect and confidence in him and his office and the way that you run E911. And I think that I think we all feel better about that. I like that we're getting a new medical director for this. I think that we probably, the salary is a little worky to me. I don't think that that's where it needs to be, but that's a discussion that I would like to have with you guys later. That we will now own the software system, and I really like that because I think that just puts Knox County kind of in the driver's seat, that we keep that software as opposed to a company having it. I do like the $1 million bond. Hopefully that you never have to use it. But we've seen on other situations that Knox County has to pull bonds for things that aren't done. You certainly don't want to see that happen with an ambulance service. So there's a couple of things that I had, and then I had a couple of questions from constituents that I wanted to be able to kind of throw it at you. And then Josh, I've got a couple of things for you. Why did the mayor's office choose a response time outside the city of Knoxville that are 6 minutes later than the national standard for rural metro EMS when the standard's 14 minutes?
Sure. So what that takes into account is not only that accreditation model that you saw, that also takes into account the current state of EMS inside our county. Now realize that 20 minutes, that's a baseline. That's not their goal. Their goal is to be there in 8 minutes. That's just the longest that we will give them before we say you have crossed the line. And as Commissioner Frazier pointed out, in those high acuity calls, you will have a medical first responder 99% of the time from our fire stations as well. Our partners in fire are amazing that way. I believe Mr. Seymour told us that they ran almost 5,000 calls last quarter. So it's not that somebody won't be there. It might be that somebody won't be there to take you in the ambulance, but that's how we got to that number.
Okay, thank you for that. This is nothing, and I understand that this is nothing that County Commission or Knox County can force. But this is something I, as a commissioner, and hopefully the rest of the commissioners will agree that I believe we need to sit down with the CEOs of the hospitals in Knoxville. We need to sit down with the fire department. We need to sit down with the ambulance service. We need to sit down with E911. We need to have a very open conversation of the fact that we all are working for the same goals to take care of our constituents in Knox County and their health as quickly as we can. I said this a couple of weeks ago. Unfortunately, I had to be at the hospital with my son last month a couple of times. And unless you've been in there, and I think every commissioner needs to go in and you need to see what it's like. Out in the ER might not have looked as bad, but when you get back there and there are beds lined as far as you can see on both sides of the hall, is a little unnerving. When my son had, a nurse that had 15 patients, he was fabulous, but that is not even acceptable. There again, that's not our purview, but it is our purview to say this is more than an ambulance problem. This is a medical problem that we have. And this is multi-layer problem that we've got in Knoxville. And there's a lot of things that I think don't want to be talked about, but I think that they need to be talked about. So I think it needs to be a hard meeting where everybody kind of checks their feelings and their egos at the door and says, we're going to work for the county and we're going to move this forward and make sure that we're taking care of everybody. So I would like to see that. I don't know how that we can perform that, but hopefully my colleagues will agree with that and we can get something going. Help me to understand what new system might be used in the field. So the mission area is, if I'm understanding it, about 4% of the calls. I could be wrong in that percentage, but I need to know, is there going to be a paramedic that's going to be there? Is there going to be nurse? Is it teledoc? Is there something that is going to be performing for people that don't necessarily need to go to the hospital, but they need to see a medical provider? And that might be a question for Josh.
Sure, I'll take that. The goal is obviously to get the care to the patient, all patients, as quickly as possible, right? All of them don't necessarily require an ambulance, lights, and siren. All of them may not require a fire department. All of them may not require an ambulance to transport them to the hospital. But certainly the opportunity is great there in that one particular part of town where we do have a very large utilization issue of the 911 system. As Brett mentioned earlier, and I think I said before, the goal is we all got to come together to figure out what's the best solution for that. I think it has to be members of the health department, members of the fire department, the city fire department, law enforcement, and everyone. Some concepts that we certainly have explored and ideas that we have thought of are, can we put a paramedic or call it a crisis response team, call it whatever you want, in that district, and where they can offer real-time virtual care to a physician to eliminate the transport to the hospital potentially. Many of these patients, once they go to the hospital, we can't leave them because of their particular complaint or their particular issue. And that's what really causes the problem. The best case scenario is utilizing technology that we have, unified medical director, and partnerships with all stakeholders to best solve that problem. So I hope that answers your question.
Yeah, I think we don't need to kind of put our heads in the sand that that's a major problem. Sure. And it's becoming a major problem all over this county. And I think people have to be aware of that. And I'm glad that you said the police, because I meant to say KPD and KCSO. I want to be in that conversation. There was a couple other things. Help me explain why, and I guess maybe I'm confused on this, but why the ambulance service, and I'm saying AMR right now because that's our current ambulance service, they're transporting deceased individuals as opposed to the medical director transporting deceased individuals. Why is that happening?
The medical director isn't here, so I will do my best to articulate that. The transported deceased and even some of the behavioral ones, which I believe you had questions about, that is a 24-hour-a-day, 7-day-a-week job. Our ambulance services, they are already working those particular hours. For us to try to find somebody to do that, say, bidding that out, the staffing for that is extremely challenging in that you have to be available 24 hours a day, 7 days a week, nights, weekends, holidays. And so that becomes very, very difficult to find.
I understand, but we're sitting here saying that we can't get the ambulance on time to people who need to get to the hospital to be saved. And we don't have another area that comes and takes deceased people.
That's a great point. And one of the things in the new contract is we don't require an ambulance to transport that deceased individual. We've done all that we can do for that person on this earth. We just request that somebody from our service provider go with a respectable vehicle that can perform the job and do that for us. And in this iteration of the contract, there's actually a performance measure to that, to where prior there was not. So hopefully that gives some release to our law enforcement agencies and those responding to that.
Yeah, I think that definitely is something that needs to be looked at. There was one other thing that I needed to ask. With AMR, on your staffing, and I don't think that this is a surprise to anybody, that since 2020, nobody can get anything. I mean, you can't get workers anywhere. You're not getting workers that want to be in the medical field, law enforcement, EMT, you're not wanting to do anything. So your challenge is high, just like it is with the hospitals. What I see with the hospitals, you have a lot of nurses leaving the hospital, going to a lot of clinics that do Botox and medical stuff and that kind of stuff because it's great hours and you get paid well and you don't have holidays and you don't have sick people. I can't blame them for that, but that's not helping our situation now. Just like you guys, it's not helping your situation. I would like to see a plan in place of recruitment and really going into the schools, going over to Pellissippi, going over to Roan State, and really hammering getting kids to come out and get excited about EMT if there's, things that you guys can do. So that's not necessarily a question. It's just something that I would like to see maybe as a proposal that you guys would be interested in kind of showing us what you are trying to do on that.
Yeah, happy to provide that, and we're certainly interested in, we do have a recruiter locally. Our supervisors will attend health fair events and all the things. We're doing that now. And I will just say, I think it's partly wages, don't get me wrong. I think the wage war continues, and not just with competing, similar services, but more with, other things that we've never competed with before. But most importantly, I think folks want to know that, number one, EMS providers, it's a calling. If they're doing, nurses and everyone, if they're doing it, they're called to that and they realize it.
Right.
And we have to acknowledge that as leaders in the industry, that we're here to help your calling become something you can afford to live on. But most importantly, it's about the culture, and it's about the work-life balance and all the other pieces of it. It's not just about a dollar. And I think we have outlined, some of our challenges and obviously some of our solutions to those problems. To where recruiting and retention can certainly be improved. I will say that through the RFP process, it certainly creates some anxiety among our workforce for obvious reasons. But even since just last Thursday, when the intent to award was announced, we already started seeing momentum and the buzz kind of pick back up again, and the excitement of let's get to work. Let's start solving the problem. So,
okay.
But happy to provide details on any of our recruiting.
Yeah, just anything that you guys come up with as a company
Absolutely.
that, can kind of guide us. And then I'll close with this. I think wall time is extremely important. And I've had that conversation with AMR that, and we never really have gotten the full understanding of who's responsible when they drop the patient off. What I understand, it's the hospital's responsibility when you hit their property. My problem with that is, yes, I think that's exactly what you need to be doing so you can get that truck turned around and get back out. The problem is we don't have the staff in the hospital to be taken care of. And if you are an EMT or a nurse or a doctor or whatever, your main job and responsibility and passion is to take care of that patient and not drop that patient off and go. And if you've got a nurse that's got 15 patients, she can't be, it's not humanly possible. So I think wall time is a major issue, and maybe that will come out of that meeting with everybody if we can put everybody together. I think they have done better, and I know that Covenant is you're going to have kind of two different ERs now, where you're not going to have, your really high illness to your next ER, and maybe that will help on that. But I think wall time is a problem. And obviously, from all my constituents, the response time up to 20 minutes is, that's where they're kind of losing it. So I think those are some things that we need to look at. Thank you.
Commissioner Schoonmaker?
Thank you, Madam Chair. One of the benefits of going almost last is that most of the good questions are already asked, but I've got a few anyways. Director Pardon, this body in January, as you stated, appropriated $125,000 to Fitch and Associates to develop the guide work for an EMS contract. How come we didn't let that play through till we got the final report? Why did we have to go in midstream and take their draft report and use that as the guide to do the RFP?
We're using their final report.
You had their final report. We got the final report last month. I think we're working off a draft report, were you not?
The basis of the response zones and all of that, yes, that was what you would consider draft, but it was all built off of the same data as Commissioner Jay was talking about.
Okay. As most of the commissioners have said, we're concerned about the response time, and particularly in the Fitch report on page 13, it identifies the town of Farragut, which is in my district, as the number 2 entity that requires ambulance service. And in that same report, we're now going from the current contract of 17 minutes to up to 20 minutes. And on page 15 of the Fitch report, it specifically says that the contractor did not meet the 90th percentile requirement for the years 2021 and 2022, even with the 7-minute allowance. So does someone look at this from a different angle and say, well, now you're going from 17 to 20 minutes to allow the contractor to try to hit that 90% threshold?
I suppose you could take that outlook. I look at it the opposite in that your current time is more than 20 minutes, so I'm actually pulling that number back down.
Okay, so you're saying a call to Farragut is more than 20 minutes currently?
Yes. Well, in the data of 2022, all of our outlying areas that were not in city incorporated are over, with the exception of what the district is called PAL. It's AMR data. I'm not sure how large that is, but with the exception of that, yes, everybody was over 20 minutes. The way that the prior contract worked is that the vendor AMR, or any vendor that we would have, they could put all of their assets into the center of the city where over 90% of the calls are, meet their compliance needs for the contract, and then the rest of the county, not necessarily flounders, because like I said, medical first response will be there to you, but not in 10 minutes or 10 plus 7. We were experiencing over that. So this new contract forces them to put assets out into our county regions to meet the 20-minute 90% of the time. Okay.
And then in the information that you provided to me earlier today, you talked about your department fined AMR, the different, for the last 6 fiscal years.
Yes.
And in fiscal year 18, it was only $116,000 basically. But last year, it was over $1 million. So if they're not meeting the response times, and now they're paying tenfold more than what they were in 2018, how could the committee keep scoring them so high for response times? And then the other thing is, you mentioned in here in your email that penalties that this body waived totaled $8.1 million. Was that for the same 6 fiscal years, or is that just the last couple years?
Just the last couple of years where amendments came forth.
Okay. And that's where we could have collected the 8.1, but this body gave them a pass in hopes that they would use that to improve their situation.
Yes, sir.
Okay. I guess this would be a question for AMR. We continually heard that there's a labor shortage in ambulance personnel. I noticed that you closed your Davidson County office this year and laid off 72 employees. How many of those 72 employees were sent to Knoxville?
I was asking Josh, I believe we retained 5 employees that moved over from Davidson County. We did offer, obviously, relocation opportunities and whatnot for those individuals to come over to Knoxville.
Okay, all right. Is the appropriation of the $2.1 million going to come out of the Health Department's budget?
That would be a question for Director Caldwell. It's not currently in my budget.
Okay. And in the RFP, I noticed that the, where is it here? You could ask for a audit of the ambulance provider. Did you include that in the new proposed contract? It has an option to require an independent audit solely at its discretion.
Yes, sir.
And at the contractor's cost.
Yes, sir. We're using that. If you go into the contract, there's a buffer there that will say if our awarded vendor has a profit of more than 12%, then the county does not need to subsidize that operation.
Okay.
Obviously, they're doing well, so they don't need our funding.
Have we ever done an audit under the previous contract?
No, sir.
Contract that wasn't in there? And was there ever the part in there that said we had the option to inspect the ambulances?
Yes,
that was
sir.
in the
That
RFP?
Yes, that was in the prior. The state annually inspects all ambulances, and we receive an asset list. Steve Hamby, or prior to that, Larry Hutzel, the emergency response coordinator, he actually goes during that audit and inspects those as well. And then we also have the ability to, anytime that we would like, inspect.
Okay, okay. And then for my education, if a call to 911 for an ambulance within the city of Knoxville, does a city fire vehicle respond first and an ambulance second?
Many times. Sometimes an ambulance actually reaches there before the fire department does.
But they're required to go at the same time?
Only on your high acuity calls, your priority 1 calls.
Okay.
So if you stubbed your toe, Mr. Spencer can tell you a story about that. Your low acuity calls, we do not dispatch fire on. Just high acuity, life-threatening calls.
Okay, and then, we have no formal agreement that you stated earlier with the City of Knoxville Fire Department.
There's no formal agreement. By state statute, they're a first responder, medical first responder, and that's how they roll.
Okay, and if a City of Knoxville fire or police officer takes someone to one of our hospitals, do you get a report back that they did that transport because they didn't want to wait for the ambulance to arrive?
I've only heard of that 1 or 2 times. I don't know how often that truly occurs.
But they're not, the city's not required to notify you that in place has transpired?
Typically, if that were to transpire, I will get a phone call, typically from Mr. Van de Vet.
Okay.
But there is no formal notification of that.
Okay, and the other thing is, under this contract, if when an ambulance is dispatched to a neighborhood, does the time stamp end when that ambulance crosses the threshold at the entrance to the subdivision, even though it might take 2 more minutes to get to the location?
No, sir, at the location of the call.
Okay. And then the other thing is, I guess I kind of feel the same as Commissioner Jay, where, this has been kind of a hurried process where everything has to be done because we're up against this February 1st deadline. And I have a good friend who calls this government by ambush. And what that means is, we're stuck because we've got to make a legislative decision to go forward, but we really probably haven't had enough time to really make a great decision. But now everything has to be in place by February 1st. Thank you.
Commissioner Durrett?
Thank you, Madam Chair. You almost got away with the full commission not questioning you guys. I do have a few questions that are more city focused because my district is completely within city limits. Mr. Jovanovich, earlier you said all agencies will be coming together and this would promote full transparency. So are those communication lines, to kind of go on what my colleague was saying with KFD, are those lines open? I have received complaints even from KFD employees that care is being received within that 3 to 10 minute time frame because they are there on those high acuity calls. The problem is transport. So I guess my question would be, are we making sure they are looped in this if there are transport issues and that sort of thing? But also, what are your plans to improve that in those scenarios?
No, great question. And something that I said earlier, just feel like we haven't done a great job collectively together as all first responder agencies in coming together. I think the unified medical director, one medical director over all first responders, will help tie us together for all the right reasons at the clinical level, which is focused on the most important thing, which is the patient. But no, I think our vision is to continue to expand the work that the health department's already done with the task force. We proposed an EMS oversight committee, which I think would have members built from representation of the fire department, sheriff's office, police department, all stakeholders. I think that's something that has never been done before. And if it has, then it's fallen by the wayside. It needs to be rekindled under this new expansive Knoxville 2.0. But that would be our intent, is to quarterback and bring all of those parties to the table to work on alignment of expectation, alignment of protocols, alignment of handoff. I think we found success where we work together, we train together, we have aligned incentives, we have aligned expectations. And again, I think the fact that we'll have aligned leadership from a medical director perspective will certainly hold that accountability.
All right, thank you. Another major complaint, of course, and we've heard it here tonight from several other commissioners, is wall time being a big issue. Again, relating back to transport times, because your buses are held up at hospitals waiting with patients to get into rooms or to get transferred into other care at the hospital, and that's holding up your buses from being able to reach other calls. Blame game aside, yes, that is the reality that we are all facing in any kind of emergency response situation. It's not going to be fixed overnight. At this point, to me, it doesn't matter who's at fault. It's the system. And as a result, I feel like, of the pandemic, and we could go on and on. In the meantime, before we do get that big fix, what can you do? What kind of out-of-the-box thinking can you do to kind of reroute those buses, go beyond this problem and get them back on the road? Because, we're talking about this Knoxville 2.0, all this innovation. I want to hear your innovative thinking.
Yeah, I think it's just expanding on what we're already doing, right? With the nurse navigator, the tiered response, I think, is a great idea, and it certainly will help. The best solution, as I mentioned to Commissioner Frazier earlier, is truly it's preventing the unnecessary. we don't have as much of a staffing problem as we have an overutilization problem and an efficiency problem maybe. And I think, again, and I know we keep pointing back to the unified medical direction, but once we get to a point where we have everyone on the same page, aligned clinically on this patient meets, they called for this reason, therefore they're getting this pathway of care, that's the most important thing we can do to solve or help the wall time problem. There are days, as mentioned, I think in the Fitch report, under the proposed plan that you would need, I think it's 19, 20 ambulances at peak. Today at peak, we have 23 ambulances on the road. And we're still having the same issue because there's this bottleneck. And the only way we want to solve the problem is to get extremely aggressive into the version and the innovation part and make sure that rolls through. Go ahead, Brett. Sorry.
Yeah, and I would just add from a what are we doing today perspective, it backs up probably what have we been doing the last few years. And you may have heard the hospitals or others talk about surge. We essentially take a AMR funded employee and man the emergency rooms to stay with our patients so that those ambulances can get back into service quicker. We've also identified the opportunities with some partners to staff because we recognize part of the hospital's throughput process or bottleneck becomes they can't get patients off the floor to move the patient from the ER up. So we've partnered with several hospitals on discharge lounges, again, manned by AMR to help the hospitals with their throughput challenges. I think, and I appreciate you referencing Knox 2.0, I think there's some additional technologies where we could put technology within the emergency departments that will show all inbound and outbound traffic, which may help the charge nurses and whatnot better prepare that they've got 5 ambulances coming through. It will also produce some color coding, which would allow them to know that they've got 6 ambulances that are on the wall and have been here in excess of an hour, 2 hours. I know currently today we leverage the work with the public health hospital coordinators to identify which hospitals are on diversion. And while we can certainly recommend to patients that hospital XYZ is on diversion status and there may be excessive delays, ultimately it's the patient's choice, provided the patient's in a stable scenario. It's the patient's choice to what hospitals they want to go to. So oftentimes we can make all the recommendations in the field, but at the end of the day, if that's where the patient wants to go, we ultimately have to take the patient to that destination. I will tell you, we continue to meet with the hospitals on trying to find solutions. I think the task force, which is now probably only a month or 2 old, is starting to get some traction. I think it's got representation of all the hospitals. I think we've gotten past the finger pointing and the blame game, as you mentioned, and we're starting to get down to the brass tacks of how do we accomplish solutions. And I think we'll see progress over perfection because it's not going away tomorrow. And I think we will begin to move away from this surviving mode to this thriving mode by getting all of those players to the table.
All right, I appreciate that. Moving on to, of course, one of those issues again is staffing shortages. And you discussed increasing salaries. With debt looming, how are you going to do that? I mean, I know there's subsidies involved, but how else?
Yeah, great question. Again, I want to connect you guys with the right subject matter experts from our end, and the GMR CFO Brian Tierney is more than welcome to entertain any questions and potentially be here potentially for a next meeting if needed. I don't want to confuse our debt with our sort of operating performance. Our debt is associated with capital, not necessarily day-to-day operations, and so our model is very solvent. Our model has been solvent. We continue to make investments in the community. We did almost a 20%, 17% wage adjustment off cycle in 2021 on our own expense, again, to combat the wage pressures that we're feeling. We factor that into our model going forward, and so almost 50-ish% of that 2.1 ask is going directly back to the workforce and sort of wage adjustments.
All right, thank you. And this might be for Mr. Pardon or Vandevate. So we've talked, I appreciate the contract, the new version. I like that response times are shorter, and we've got the updated response times, updated compliance zones, et cetera, et cetera. Who will enforce this? Will it be that new unified medical director, or will it be Knox County? Or who is actually going to hold them to the fire if compliance is not held?
We have monthly compliance meetings, so that's where all of that would come from. Steve Hamby, our emergency response coordinator, holds that.
Okay. So, but there is a specific person. It's not
There
just,
is.
we're going to make it nice and pretty and this is
Absolutely not.
magically going to happen, because there are those days when
Sure.
like things aren't going to be met.
Right.
I mean, and then there are going to be days when, or weeks or months or hopefully years where compliance is met
Yep.
all the time, consistently. So I appreciate that. And last comment, this is just more of a comment. Commissioner Oster was referencing your recruitment and those things that you're doing. I just wanted to give a little plug to the 865 Academies. I actually sit on their steering committee, and this is a Knox County Schools initiative where we get partners to come into high schools and get involved. And there are several high schools that have a medical component to their academies. And I am more than happy to get you all hooked up with them, because there are students, I'm sure, that are in this school system that are interested in this field. Thank you.
Thank you. I have a couple of comments, and then we'll close with Commissioner Frazier's question. I agree about the response time, 20 minutes. I'm west. We have the probably heaviest population out there, and even though usage might not be quite as up, that is a real concern. And whoever gets the contract, I hope they will consider perhaps adding other stations to be able to meet that need. The second thing is we hear over and over about staffing shortages. I do understand that the starting salary, even with the last wage adjustment for a paramedic, I believe was like $16.20, roughly 16 plus. My comment to that is I do understand it's a certified program, and I was also told that it was a union negotiated rate. Having said all of that, though, I can see why, especially in Knox County, and I get having to have a calling, I come out of education, that you still have got to make enough money to take care of yourself and to feed a family. Is there anything preventing you from starting higher than the industry standard for our entry-level folks?
Sir, our proposal indicated what our current rates are that have been agreed upon by the union, the local union, and I can tell you that the $16.20 is not accurate. It's closer to $20, I think, dollars an hour starting for a paramedic.
That's not what was in your the information that was sent, but
Happy to provide that to you.
not paramedic. I'm talking about an EMT.
Oh, EMT. I'm sorry.
Yes.
I think that rate's depending on the classification of EMT basic or advanced. That's probably the average, probably around $16 or so an hour. I think it's important that to note there's also other incentives, nights and weekends, shift differentials, and
Yes.
shift incentives and bonuses and things of that nature. Again, we agree that number probably should be better. And part of and that was like Brett mentioned, part of the subsidy ask was really devoting a lot of that, dollars back to the workforce.
Well, thank you. I hope you will continue to look very closely at that. As you know, essentially, you don't even have to be a high school graduate, and you can make $16 an hour working in a fast food restaurant. So I think if we're going to really attract and keep and nurture some of these, especially entry-level folks, that we have got to keep working on getting that starting rate up. So I would really encourage you to look hard at that end. And on that, I will turn the final questioning over to Commissioner Frazier.
Thank you, Madam Chair. Just a follow-up comment and in close. We've heard a lot of great discussion, a lot of things to think about, especially as we move forward through this process. And we've also heard a lot of discussion about positive outcomes and productive paths forward, kind of hinging on the implementation of the county medical director. As this discussion continues, I think we really need to look at this being a full-time employee because they have a lot of work to do. And I just think that the county in general would benefit more from having a full-time medical director. So I would ask that some consideration and a continued discussion be had on that topic.
Thank you. And seeing no other lights, we have run over slightly. We appreciate everyone's time. And if I'm assuming we have any more questions, we can certainly come to you, any of you individually. So thank you so much. This meeting is adjourned.